Hi, everyone. How are you doing? Welcome to our psychodiagnostics course. I'm Lindsay DeMuse. I am so happy to be able to meet you all and work with you as a group. This is a course that is very near and dear to my heart. I put a lot of time and focus because I just think that it's such a fundamental class. Think it's foundational. I don't know if that's really like a MAC sanctioned word as far as it being a foundations course, but it's just there's something to be said about how important learning the DSM is and learning about how to be able to diagnose and understand our patients, our clients from a diagnostic angle. And so I'm going to take you through that process. I will start by taking you through the syllabus, however. This is obviously not a new part of the process for you all as it relates to being in this class, but just looking at the course learning outcomes, that's my biggest focus is familiarizing you with the DSM, 5TR, really helping you to understand not only what's in the DSM, but how to use it, how to understand it, how to interact with it. We do have other textbooks that we focus on in this course, but as far as I'm concerned, the DSM is the most important here. So I really want all of my students to leave the semester with familiarity, fluidity as far as diagnostic terminology, symptoms that go under key diagnoses that we study, how to be able to use your conceptualization to not only see a client or a patient in a clinical setting, but to be able to have an appropriate diagnostic curiosity that's developed and to be able to go through like a mechanical systemized approach of taking symptoms from what's being said, how it's being presented, and go through the fundamental process of honing in or homing in. I just learned this. It's not honing in, it's homing in. And now every time I say it, I think people think that I'm ridiculous or stupid. But it's like, no, that's actually, look it up. It's homing in. Anyways, I digress. Homing in on what key components belong to which diagnosis. And so that's really what we're going to be focusing on. Certainly, I will be helping to deepen your ability to talk about cases from a treatment team type of perspective and in a group of other clinicians, being able to really think out loud about what you're seeing, what your clinical gut is saying about what's coming up for you as you're presented with a case and being able to talk about that cohesively, come to a formalized understanding and a working diagnoses or working set of diagnoses. I think that's what I was going to say earlier before I got stuck on the homing in process. But then what we will also do is introduce you to the idea of different evidence-based treatment components. I'll introduce you to what it looks like to start working on a treatment plan and how that gets developed. Again, I know that depending on where you're going to be, I know you don't know this, where you're going to be in your practicum sites, that some of that information will be sharpened and some of that information will be lost. But I think you will always have opportunities and there will always be a necessity to be looking at something from the lens of a treatment plan. In my private practice, I'm not required to do treatment plans. I don't do treatment plans for every client, but the ones that I know I'm either really needing to stay on top of because the nature of their presentation, just due to the complexities of their cases, like that's where I really continue to develop a treatment plan. I was just working on one actually for a client. And so, yeah, it's just, 17 years I've been doing this and that none of this is lost on me. So that's what I try to do is to make sure that I'm giving you the opportunity to start this process of knowledge, of learning, of application, etc. So that's what our course learning outcomes in a nutshell are going to look like. I don't understand this credit hour distribution graph. I'm sorry, I've looked at it like a million times and I don't know how these numbers are derived and what pre-course hours or course hours look like. All I will have to say is that there is a lot of reading. I'll talk about how I try to break this down and really how I try to make sure that you get as much out of this as possible as far as comprehension and preparation. But my ask is that you make sure that you prioritize the reading for this class. I know that every professor talks about prioritizing the reading. This is not going to be a great experience if you don't do the preparatory work beforehand. So I do use a flipped classroom model. And so that requires not only doing the reading, but making sure that you are caught up on the lecture. Again, I want to talk about this as we get further down the line. But I will have guided lectures for you. I have PowerPoints that I've spent a long time working on because there's a lot of content in this course. I try to make this as easily digestible and dynamic as possible. It can be such a dry course, and this is going to be my fifth time doing this. Uh, let's see, how do I say this? I have worked very hard to make sure that this has evolved into a course that is functional and is really hopefully fun to learn about. And so, but that requires commitment on both of our ends. And what that means is that there's an expectation of reading and preparing yourself with the lecture. So, yeah, that being said, our course assignments breakdown goes into our exams, our case conceptualization assignments through the I Can Start framework. You'll have a group presentation that you all do once this semester, and your attendance and your professionalism, these are all going into your grades. Here is the point designation. So your exams are 150 points each. Together, they comprise 38.75% of your total grade. It used to be 50%. I've changed it. Um, I'm also changing this. Your exams, well, the exams in this course used to be just written exams, and I'm going to try to make them more dynamic. I said I spent a lot of time on this course, and I really mean it. And when we meet and when you start to work with me, I hope that that will ring very true and be evident. But what some of that looks like is continuously building the ship as I sail it. And so I have lots of ideas in my mind that I just don't have the time and the focus at this point to execute. But ultimately, what I'm trying to say is that your exams are going to be a combination of written and an oral component to this. As I said, I'm going to be focusing on shaping your experience and preparing you for treatment team settings and case collaboration. And so I'm going to incorporate that into the midterm and the final. I just don't know exactly. Got you. There's a fly that was buzzing around in my office, and I've been trying to get it for the last 30 minutes, and I finally got it. Anyways, but I just don't know. With the exams, I have yet to finalize them, and so ultimately, it's going to be conceptually written and an oral treatment team type of hybrid aspect to it. You do have study guides that are going to be available to you. I try to be as specific as possible about what's going to be on the exams without telling you exactly what that's going to look like, but I really try to equip you with this because otherwise the information is nebulous. And so I aim to be as directive as possible. I always get good feedback that the study guides are helpful, and if you follow them, that you will be adequately prepared for the exams. I'll go over the case conceptualization assignments in a minute when I get to the calendar. Um, and I'm going to go into your group presentation in a minute too, but just know how I know, again, every professor says this with regard to attendance and professionalism, but it really does suck if you're not here. Um, I understand that life happens, people get sick, we have things that are already planned out. This is a course, though, that is meant to not only be digested in bites, but meant to be applied, and the experiential component of that is so essential to just your competence and confidence. And so if you're not here, it's a lot for me to have to catch you up if you're not here, you miss these aspects of it. And I really try to make this learning environment fun too. And so, I don't want you to miss out on the fun. But if you know ahead of time that you're going to be out, please don't hesitate to email me. You can email me or message me. My name is Lindsay DeMoose, like Vamoose. Here is my contact information. I list my phone number because sometimes things happen like immediately and you need to text me. That is fine within reason, hence why it's there. Just be responsible with the freedoms that you have. I say this for a lot of different things, but especially with contacting me, or in this case with contacting me. Let's see, I'm skipping around. So professionalism, I say this just as important as physically attending is how you attend. I'm going to read this because I just want to emphasize it for a fact that these classes are designed not only to help you just again digest the material, but I really, as I said, want to build your confidence in discussing cases, giving you permission to think out loud, giving you permission to be wrong. That is so important. And I don't know what you're thinking if you don't share that. I don't know what's going on with you. It's helpful. That might be if there are barriers to you being able to participate in the course, to complete information in the course, that, again, life happens. And I have just experienced information or just experienced different types of situations with students in the past where they do not give me a heads up about what's going on in real time and have said, "Oh, professor, by the way, 5 weeks ago this happened, and that's why I haven't been able to do this, this, or this." That is vital information for me to have as soon as possible. Not details about what's going on in your life. I don't need to know that if you don't need to share that. That's not what I'm trying to say. But if there's something that's happening that is preventing you from being able to show up, it's preventing you from being able to do the work to your fullest capacity, that's going to be useful information so I can ultimately support you. I cannot support you with what information I don't have. And so this is where I highly encourage just-in-time communication, just-in-time feedback from me. Although there's a lot that I have already developed, and I would say that my competency in terms of just knowing this class and being able to really direct this class as best as I can. There are lots of things that I miss. There are lots of things that just, my life gets in the way. And so please, please, this is where I'm emphasizing the importance of professional effective, clear communication. I promise you, this will be a skill that you need forever. It's a skill that's always cultivated and in an ongoing way, but it starts here. It starts in this program. So yeah, so I will repeat this. I can't help you with what information I don't have. So I can only support you with information that you share. If there is something that is hindering this process for you. I will stop repeating that for now, but I hope that you get it. um, just let me know how I can help you. And you can ask anybody that's been in my classes before. I really aim to be as helpful of a professor as possible. I want to make sure I go out of my way within reason to help support you in this class. Again, it's tough. It is not easy, but I dedicate my time and my effort to making sure that you all grow. And if I don't have information about what's getting in the way of that, you're not going to be able to grow in this class, simply put. So let's be collaborative as we traverse this next 16-week period of time together. Okay? Okay. I think that's really key. Just but the breakdown of points, so 150 points for each of your exams. You will have reading quizzes through most of the class, but when we start to get into the actual diagnostic sections, you will have reading quizzes to be able to keep you accountable for the reading that you have hopefully done. You have 5 different opportunities to apply what we've talked about in a very specific format called the I Can Start format that's introduced to you through the Treating Those with Mental Disorders textbook, which I more formally or more commonly refer to as the CRESS textbook, pardon me, KRESS. Again, you have your group presentation, you have your attendance, your professionalism, which are both worth 10% of your final grade. Again, let me know if you're going to be late. Let me know if you're going to be absent. Classroom etiquette. Because of the fact that we're doing a flipped classroom model, you are not really going to need to have your devices out. This is meant to be much more experiential. I want to see your beautiful, wonderful, wonderful faces that are engaged. I will be very clear when I need to redirect you to put your devices away. And so that's really in my evolution of shaping this class to a flipped classroom model. Part of that is because engagement through PowerPoints is we're not good at multitasking. There are lots of studies that show that we're not good at multitasking, and so that's what I try to walk the talk in that regard. Let's see, I think that's all that I wanted to go over as far as the syllabus components. But here's the course schedule. I'm going to post this here. So this is going to look different as far as introductions, but I'm looking forward to you all introducing yourselves and learning more about you and why, just what you think, what you're coming into this class with, et cetera, et cetera. There are lots of questions that I ask of you all that I want to hear about as far as how you can present that. So yeah, so here's an overview of the class. This is where, so week 4 is where your reading quizzes will be embedded. I'm just going to open this up and let you know. Okay, so I'm going to just show you, as I said, I'm building the ship in a way as I'm sailing it. And so what I do not have online are the guided lectures. You do have all of the Canva PowerPoints that are available to you already. And so these are live links that are view only. You know what, I'm going to just, this is, I updated this. You know, I'm just going to say this. Uh, so I am going to link my guided lectures in every single module. I'm going to probably cut out or repeat this part because this just needs to be updated as I have not yet recorded the lecture for, I haven't yet recorded any, most of the lectures, pardon me. Some of them have already been recorded, but I need to do a lot of that over the next couple weeks. What I will tell you with the flipped classroom model is I know that everybody learns differently. And so how I've done this before is told everybody to start with the DSM, read the reading from the DSM, then read the corresponding CREST chapter, and then review what is indicated from the Handbook of Differential Diagnosis. But if you're somebody that you really do better with audio, an audio component, I get pretty in depth and in detail in the lectures. And so that might be something where you actually start with the lectures first. It's up to you. It might be a trial and error process, but maybe you go over the lecture first. Most of the lectures are going to be about 2 hours. I will have them recorded on YouTube so that if you are somebody that can and wants to speed up the process or the playback speed, you can do that. It's up to you. So you might want to start with the lecture and get the audio component of that down and follow along and then open up the DSM and then do the reading and then go through the corresponding texts. You know yourselves better than I do. If you're really struggling with how to figure this out, and especially our midpoint checkpoint really is the midterm. If you're like, hey, Lindsay, like I am not knowing how to digest this, then talk to me. We can figure out a plan. Everybody, like I said, everybody's different in that regard. And sometimes it's really an easy process to absorb, and other times it's not, and it takes some troubleshooting. So again, that's where I really want you to come to me and share with me if you need any sort of clearer direction. I'm happy to be able to assist you in that process. So that's the example. But so for every single week, you will have this voice guiding you. I have a different microphone that I'm going to use to record most of the lectures. Again, some of them I've already recorded, and so it is what it is. I told you that most of the lectures are around 2 hours. The personality disorders one, I'm going to actually re-record that. But that's a little bit longer because I go into such detail with that. That, as far as I'm concerned, could be its own quad class, and it's not. So I really try to impart as much information as I can for you all to know. Um, just because I want to share all that I know about this, and personality disorders are so prevalent and can be very challenging for everybody. So that one's a little bit longer. Um, but so, oh, you know what? That's not what I meant to do. So for each week, in each module, you'll have an overview of what we're going to be talking about. I have inserted learning objectives, so you know what I really aim to do every week. You know, it's so funny. Objectives like haven't meant a lot to me. Especially as a student, as somebody that was an associate, like doesn't mean the same thing until you start creating content, until you start creating educations. And so, but I want you to know what's happening in my brain and what we're really going to be getting out of the course week by week. And so the first week that we're going to be meeting together, so week 2, we're going to be talking about the mental status exam. You're going to be able to better understand and describe what the components of that are. You'll be able to much more accurately and comfortably, if I can say that as this word for this application, you'll be able to identify and differentiate mental status exam components when you see someone in a clinical interview, and you're going to have familiarity about what the I Can Start framework looks like as far as assessment and treatment planning. And so I have linked everything that I can link so far, but what you will see as I go through this in the next couple weeks um, is you'll have the lecture review linked. That's going to be done this week. But yeah, that's what this is going to look like week by week. I'm trying to think of anything else I can say about that. But yeah, review this. Again, if you have any questions, here are, so for your assignments, you do not have access to the clinical information on this yet. I need to update this rubric, but again, I'm going to be working on it. So just know that you will have 5 different opportunities to see a vignette and apply the necessary information in this template that you will have further exposure to soon. One of my favorite aspects about the course is the case conceptualization group presentation project. And so everybody has been assigned into a group. You all have been assigned an actual group and a disorder. Uh-oh, did I not fix that? Uh-oh. Well, I'm going to do this. I'm going to do this after. That's weird. I thought I did put that in. Okay, I will rectify this. So when you see this, you will know who's in what group. Um, that is going to, let's see, correspond with your calendar of who's doing what when. And so your group presentations start with bipolar disorders. That starts, the first one is February 11th. Not every week has a group presentation, but most of the weeks do once we get started. Um, there's one other thing I was going to say about this. Oh yeah, I will also have a Google Doc that I'm going to link that has everything embedded in this, all of the different, it's basically a combination of the course schedule and the modules. So it's meant to be an easily accessible go-to document that you can just see everything from a zoomed out perspective rather than click, 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 if that's how your brain works. But back to the assignment. Um, what this is a really fantastic way to be able to see a pretty good Hollywood description of what different presentations look like. And so I have spent, again, a lot of time making sure that these movies are accurate descriptions, again, as much as Hollywood can do, that are good descriptions. You will be responsible for watching the entire movie and then presenting on that character. So you will present a complete case conceptualization. I want you to read this in further detail, but I'm just going to give you a quick overview. You will develop a case history of this client. You will present with different clips that really speak to important aspects of what the person looks like as far as the clinical symptomatology, how that comes out. And so you don't have to actually, oh, so you'll show a video clip in your presentation and you will actually write a mental status exam summary for that clip. This will be clear as we go through what the mental status exam is. And then you'll actually use, again, the I Can Start framework to scaffold your presentation, which is often in a PowerPoint. And so you'll go through the different components of the I Can Start framework. I'm very thorough in my directions here, so please, please um, review this in its entirety. Whatever questions you have in class, we can talk about them and answer them, but this is an opportunity to talk about a character in a movie, how they present, why they are the way that we are as much as, or they are as much as we can understand, what diagnosis we have arrived at, how we've arrived at that, what treatment can look like, what common myths and misconceptions that are existing and are known for that particular diagnosis or that set of diagnoses, how we want to educate everybody on managing those stigmas, because that's so important, especially with regard to mental disorders in general. And so, yeah, so this is an opportunity to also talk about prognosis for that person too. Even though we are not treating them in real life, it's a great opportunity to just like familiarize yourself with what that can look like and present your knowledge to the class. Um, so that, I think that's really a big part of what I wanted to share with you all. So yeah, I will fill this in any way that I need to as we go. But again, if there's anything that you're like, oh, professor, this link doesn't work, or I have questions about this, do not hesitate to reach out to me. I'm very receptive over email. I already said that, but I appreciate when, if I miss something, to let me know immediately so I can fix it immediately. This is where you will submit your light week introductions. That was the last thing I was going to do. But please read this. I know sometimes I can be long-winded. Try to be as thorough as I can. These questions, you do not need to answer every single question word for word. I know in the first couple ones I ask a lot of questions, but take answer what you will, okay? So I want to know about what preconceived notions you have about mental disorders. How do you view severe mental disorders? Are there ones that you're like, ugh, I am not excited to learn about this, or I'm really excited to learn about this, or I'm interested, I'm fearful about what this is going to look like. I don't want to work with this particular diagnosis or set of diagnoses in an actual clinical setting. What are your strengths in terms of both who you are as a person, academically? How are you going to show up to this course? Are there other cultural, spiritual backgrounds, beliefs that influence the way that you perceive mental disorders? Because this can be really controversial depending on what type of group we're talking about. There are, you'll read about this, but there are so many different cultures throughout history that don't want to have anything to do with mental disorders, like that they really draw the line at crazy and that's not okay to be crazy. And so that's really where the conversation ends. And so, what are you bringing into this as far as your backgrounds, as far as your history, as far as your curiosities, etc.? What type of population do you want to work with? Where does this come from? Are there any evidence-based practices that you're interested in learning more about? I'm going to tell you that this is pronounced ACT, not ACT. That is such an understandable common misconception, but so we pronounce CBT, DBT, and ACT. Stephen Hayes is a very interesting person in general. They say don't meet your heroes. I don't think he was ever really a hero, but he just such an interesting person. I'll talk about that later. But so it's called ACT. Now you know. Do you have any prior knowledge or experiences with treatment in general? In my last class that I taught, there were a lot of students that had been working in a treatment setting historically. So I want to know about that. This is something that I am competent in, but I am not an expert in every single chapter that we're going to go over. I'm not an expert in every single type of treatment. And so your expertise, your experience is so valuable. And so I want to hear about that too. There are going to be times where I need to defer to you. Not all the time, but that's important for me to know and for me to be able to incorporate. Do you have any questions about the course? And then in addition to this, I think you all know the drill. You get to comment on other peers' video submissions. So that's what I want from all of you. This is due by Sunday the 18th, but this can be very time consuming on my end, and I love these videos because I get to know you before I even meet you. But if you can do them sooner, that would be very helpful for me. Okay, I think that's it for me. If there's something else for me to add, I will add it, because I'm going to attach this to your lecture video that I showed you the lecture of, that PowerPoint. But yeah, thanks everybody. I'm looking forward to being able to meet with you all in the second week of this course. I'm repeating this for effect. If you have any questions or anything in the meantime, do not hesitate to reach out. But stick around. Wait, is it this way? Stick around for your lecture video. Okay, thanks.
Okay, forgive me for the beginning of this part of the lecture. When I went back to look at the video that I had completed last year, I remembered that I started recording this guided lecture when I was in my private practice. It was later. I probably was pushing myself too much. And so the beginning is just not usable. So I had to re record it, which is what I'm doing right now. I made sure that I looked at the next part of the video, but I hope that there is appropriate overlap and that I'm not missing anything. So just know that this part's just a little bit choppier than I would like it to be. For future recordings, everything is going to be smooth because I will do it in one fell swoop or one straight shot. But thanks for your grace and understanding. So this lecture, we are going over chapters 1 through 3 of the Treating Those with Mental Disorders textbook. I'm going to do my best to consolidate it and to really get a lot of information, which I'll speak to. But I'm going to do my best just to hit the points that are the most important. And so I know I talked about this just a little bit earlier on, but I was thinking about it afterward. What I had said in the video before was that you know your learning style. But again, if it's easier for you to really start with the guided lectures, and I genuinely do hope that they are an effective tool for learning, if it's easier to start that way, then go ahead and do it. And then you can go back to the DSM. Regardless of how you learn, you can go back to the DSM and do your reading and then read the corresponding CREST chapter while reviewing the handbook pages, the handbook of differential diagnosis pages. But I really do need you to watch the lecture, not only to be prepared for class, but just to know that there are things that I focus on in the lecture that are really going to be covered in the exams and are going to be covered in class. And so That's my way of telling you what I really want you to know and how I want you to know it. So that's why this slide bears repeating. And then you will have a reading quiz that is due by 5 p.m. each day. Oh, yeah, I did add that. And so you need to take it. Okay, that's enough of that. So I know, especially these first three chapters, the CREST text gives you so much information. And when I started reading it, I was like, just automatically went into the mentality of being a student, and I'm like writing everything down, and I'm like, wow, this is so much. Please know that I would really be somebody that has a working diagnosis for some sort of disorder if I made you. I'm looking at the middle screenshot here. If I made you know all of this stuff plus everything that's in the DSM, I'm sure you would label me as somebody that has a working personality disorder. Know that I'm not going to do that. That would fall under the category of like antisocial personality disorder. I am not doing anything more to be cruel. There's just a lot of information. So when you read it, if it seems like, wow, this is like stuff I'm never going to know, I'm not going to take with me, this is too much information. I'm realizing maybe I already said this in my previous introduction, but just know that like that's not what I'm going to be getting at. Read it, digest it. I will give you directives as to what to study from. There's not a lot of information from the CREST textbook that is going to be on your exams. Okay, so that's your cheat code right there. It's much more focusing on the DSM. And again, forgive me if I'm repeating this. Okay, so what the CREST text talks about as far as foundations for effective treatment is what I've deemed the therapeutic triad. This is where we're looking at the client conditions, the clinician, who they are, their competencies, capabilities, their efforts to work and set up a relationship between the client or the patient, and then the treatment conditions. And what the textbook says is that all of these factors together really allow for what we call successful treatment. This is for the client or the patient to get better, right? If you work in the county, this is going to be your service partner. That's what they call the client or the patient. But ultimately, it's a matter of, hey, what is this person coming into treatment? What conditions are they coming into treatment under? Do they have awareness? Do they have insight? Have they had previously successful experiences in treatment before? Are they coming in because somebody else or some other entity really wants them to be in treatment and they do not want to be in treatment? These factors under the client aspect of this triad make a big difference. It doesn't mean that it makes all the difference in the world, but if you're meeting with somebody and they're coming in because they're trying to get their family or their loved one off their back, they're trying to get probation off their back, for instance, and they don't have any sort of awareness about what problems that they have or what they're struggling with, that's going to be a significant uphill battle, even if you are the best clinician and the treatment conditions are good, i.e., even if they have all the time and the money in the world or the resources in the world. It's going to be tough. It does not mean that it's impossible, because that's where your skills and resources come into play to hopefully soften that person's treatment interfering behaviors, developing the relationship, allowing for safety in that relationship to be a key component of treatment in itself. But you just have some barriers that you have to encounter and do what you can within reason to work through. And again, forgive me if I already repeat this, but thinking of a client that I treated within the last 2 years, I do not treat them now, and I don't know where they are or what they're doing, but this is a 20-something-year-old client that was referred to me because I had previous therapeutic contact with a removed family member. But I was asked to support by this client's mother to support this client in my private practice. The client came in with significant delusions, psychosis. Psychosis might be too big of a word. They had a lot of delusions that they did not want to talk about because that was part of their paranoia and their delusions. And so and they were also smoking cannabis and drinking alcohol. The cannabis is psychoactive. We'll talk about this more, but ultimately, when I started with this person, they wanted to work on how to develop job interviewing skills and how to be able to get a job and keep a job. And their perspective of why they were struggling with this was because of their anxiety. It became clear to me just how internally preoccupied this client was, and how he had auditory hallucinations. He had a lot of paranoia. He was essentially told that he couldn't talk about any of this stuff because a government related entity would be out to get him. And so as we tried to continue in treatment, it got more and more difficult where, oh gosh, all the things that I did to try and soften this person's ability to be in treatment, to develop a relationship with them, to get them on medication, like nothing worked. And I tried twice and it just ended terribly. Like this is where I did not do a very good, I don't know. There are just a lot of takeaways that I had as far as how I could have approached things, but it was just really difficult in general, because they didn't want to be in treatment and they didn't really have a lot of capability in showing insight and awareness. And this is just the nature of schizophrenia spectrum disorders in general. It's just not always a positive treatment experience because of the nature of what's happening internally. Again, we'll talk about that. But, compare that to somebody who's coming in and they're like, hey, I'm really having awareness about my relationship with my mom. And I see that the way that I act with my mom is very much interfering in our behavior. It causes me a degree of distress. I really want to work on this. I've had positive experience in the past with a therapist. I'm totally bought into this. So when can we start? That is the dream client because it's like, great, let's do this. Even more so when clients are like, I want to do internal family systems because I know that that's going to be really helpful. And you're like, yes, that's exactly the type of treatment that I would prescribe. So let's do it. That's very ideal. We just don't always get that. Sometimes it's just really somewhere in the middle. But ultimately, the biggest factor in ensuring some sort of success, or I'm going to use the word efficacy like I have on the slide, in treatment is the relationship that you get to form with your client. So, regardless of whether they have insight or not, regardless of how motivated they are, you can help with that stuff. There are different tools that we have, different interventions that are evidence based that we have with motivational interviewing, with how much time we take to join with a client. I mean, that's so important and crucial. And their factors can be worked through. The other component that we have here are the treatment conditions. And so I think in the next splice of the content that I'm going to connect this to, I talk about one of my long-term clients that I've been working with in my private practice who has a lot of challenges that they bring into the treatment setting with regard to personality, with regard to anxiety, with regard to obsessive compulsive behaviors, with regard to overspending. Like there's just so many issues. But when they are in a lot of supportive environments, they do better, a lot better. And I would say that this is the case for most humans. When they get out of their place of living and they socialize, when they go into intensive outpatient programming, which they're currently a patient now, they just do a lot better versus when they don't and they isolate. They don't see anybody for weeks at a time. They engage in maladaptive behaviors such as shopping, such as eating. They just decompensate significantly. And that's what I talk about in the video that I splice in, was that we've had a history of trying to get this person in for intensive outpatient treatment and insurance gets in the way. And so fast forward to today, my client is back in the senior intensive outpatient program at Sharp Mesa Vista, and they're doing pretty well. But what the treatment conditions aspect talks about is, do we have the right level of care for them? Do they have the resources to be in treatment, i.e., can they pay for it? Do they have insurance that will allow for treatment to match up with your treatment plans as far as time, as far as the amount of time that you have to really work through the different issues to be able to achieve short term and long term goals. There are clinicians that do such a good job in being able to do short term treatment. I'm not one of those. And maybe this slide is evidenced by that as far as just, you know, my desire to sink into subjects and to really talk about them. I'm not saying that I hold up treatment because I like to talk a lot in therapy. That's not it. But like, I just, some clients really need a lot of time and do not do well in short term treatment. If we're talking about a singular problem that we really have good evidence base for as far as identifying appropriate interventions and being able to apply them, and the client can pay for treatment, their schedule lines up with yours, they can get to your treatment facility easily, then that can really lead to, again, effective, successful opportunities in working through treatment and fixing problems, right? But if your schedule doesn't line up with theirs, if they have difficulty being able to come in regularly because they can't afford it, that doesn't mean necessarily that your rates are too high. But if they're not prioritizing payment, if they are using insurance and insurance is not authorizing treatment in an appropriate manner, i.e., they're only giving you 2 sessions when you need 20, then these treatment conditions are not going to allow for effective opportunity or for opportunities for effective care. So I'll talk a little bit more about this when I splice this in, but this is where I'm going to leave you and hand it off to myself.
Just the discussion about in the text about accrediting bodies. The only reason I wanted to just delve into that really quickly with you is just to give you some like awareness about the backgrounds of why we have to do the things that we have to do in a lot of bigger institutions or at at different bigger sites. There's this double-edged sword with regard to being accredited, where on one hand, you want to work, if you're going to work for a bigger organization, institution, et cetera, you want to be accredited because what the accreditation essentially demonstrates is that this is a site that follows evidence-based practices. They have safe, effective practices. They maintain a particular level of standard of care. And so without accreditation, that really demonstrates that that the treatment could be any sort of degree of good, bad, whatever, that it doesn't have to follow a specific standard of care. It's not required to maintain any sort of minimum requirements of how we do treatment, how we run treatment, where is the methodology behind that, et cetera. So there is a whole host of different outcomes that could happen when somebody is not following a structure. The downside is that, so essentially, like, if you're working for a place that's accredited, then you know that there's a particular quality of care that they have to provide. And so I mean, and that really protects the public, ensures that like they're doing something right. Um, Now, the downside is that it can take a lot of work to meet the standards, and the standards can be really demonstrative of a lot of particular things that has to happen. So at Sharp Mesa Vista, this is what I can speak to because I was there for a long period of time. It's like there are a lot of minimum standards that need to be met. There's so many standards as far as just what the treatment planning looks like. The treatment planning has to be initiated 7 days after 7 calendar days after a person starts the intensive outpatient program, and it has to be updated and maintained with individual goals that are different every single time. Every 30 days, there have to be measured-based care scores that are entered into each treatment plan update, and that those scores have to be incorporated into the individualized treatment plan goals, objectives, etc. So there's that golden thread that gets followed, but it ends up at worst looking like a lot of documentation. And so that can be really tough where, and this is what when I came over to Sharp Mesa Vista, at first I was at the Sharp McDonald Center beforehand, and we in both sites have joint commission essentially reaccreditation every few years. And the survey period is just really stressful and overwhelming, anyways, because we got to have all of the charts in a row. Everything has to look really polished and perfect. And that can just put a lot of stress on all of the clinicians, on the leaders, etc. But, I remember coming over to Sharp Mesa Vista for after I was at Sharp McDonald Center, and the team that I was leading, they were OGs. They had been doing this work since the day of paper charting, and they had a lot more freedom to spend time with the patients. They had different choices of how they wanted to run things. It was a lot more oriented per their statements. It was a lot more oriented toward patient care. And the challenge is that, they viewed it that they got to do a lot less patient care as the documentation standards piled up, and they really had to do much more stuff behind the scenes. And so that's the trade-off, is that on one hand, like, we know that we're providing good care because there is a whole slew of different requirements that really speak to what goes into good patient care and how people get better. And again, there's the evidence to back that up of, like, there's all this research that is done into these different types of options that we have for people that shows that they're effective models for recovery. But the downside is that you're really limited to, not limited, but you have to follow that plan of care. You have to follow that methodology. And so sometimes I think it can be more stressful and take some of the creativity out of this process. And for anybody that goes into practicum next year, when you're at a site that does not have a lot of structure, you'll see the difference because, and I think that there are some things that are really fantastic. You have the ability just to do whatever you want. And then I think there are times where I hear from my practicum students where they're wanting more directives in terms of, I want somebody to teach me how to do dialectical behavioral therapy, DBT. I want somebody to really require how I'm doing this particular thing. And it can just be challenging to have not enough structure when you need some, or have too much structure when you just want a little bit of breathing room. So that's why I speak to this. So just this goes into the I Can Start framework, but just levels of treatment. This is not comprehensive, but this is like the main type of perspective that you'll have in terms of what types of patients and clients you'll be exposed to, and different options that you might have in terms of stepping up or stepping down. But so private practice, this is individual outpatient. This is where most people are seen once a week. Intensive outpatient program, this is what I was talking about. This is IOP. It's 3 hours a day on average for 3 days a week. Partial hospitalization. This is really, as far as what I know in San Diego County, only applied or only available for those that have substance use disorders and eating disorders. A part of it is because managed care just does not seem to see the benefit of a full day treatment program, but because it's 6 to 8 hours a day for 3 to 5 days a week. And that's a lot of treatment. I can imagine that's pretty expensive, but it can be super helpful in assisting a person to transition from an intensive inpatient level of care down to a few days, or pardon me, a few hours a day, a few days a week. And so we really try to have this be like a step down plan. I know that the visual is the other way around, like a step up, like a step down plan where we want to give people the best practice clinically is to give people the most significant type of wraparound service possible for stabilization. And so that's where they might need inpatient stay of 5150, which is involuntary. It's not commitment, but an involuntary hospitalization. And so they are usually there for 72 hours or more, depending on what the situation is. And then if they need to step down after that, then we really want them to go from inpatient, where they are in a crisis situation, to individual outpatient 1 hour a week. That's a big jump, right? That's a really big gap of, like, they have somebody that's monitoring them every hour on the hour, if not more, when they're at that level of care, to just seeing a therapist once a week. You really have to have a particular level of functioning to only need that type of support, i.e. private practice. And so it's just a different type of population that might need that stabilization, but we want to try to give them a cushion or a buffer when they're going from one level of care to another so that they don't decompensate. And sometimes it's tough because, like what I mentioned with my client who was doing IOP and then insurance said, no, you can't do it anymore. And she really decompensated. Like I did not expect for her to make such a big transition away from the skills and the tools and the overall functioning that she had. It was just a big difference. But there's something to be said about how effective it is for us to actually get up every day, put pants on, take a shower, and get out of the house, right? Even if we're not doing anything that we find exciting or really want to do, there's something to be said about our functioning and how that really makes a big improvement. So that's what I've been working on. We're trying to get my client back into IOP, but that's what I've been working on with her every other day, because daily wasn't reliable, or that wasn't realistic for her, but every other day putting on her regular clothes, every other day taking a shower. And that seems to be actually pretty helpful. But that's what our treatment planning is looking like right now. And then residential treatment stay, this is where, again, insurance has been pretty stingy. And so my understanding is that people just don't have as much time in terms of inpatient treatment. And usually we see this with substance use disorders where they'll have, when I came in to Sharp McDonald Center in 2013, our patients on average, did I already say this? Did I say this in my head? They were saying like oh yeah, I did say this, 12 to 15 days, and now it's really just a few days. But long gone are the days where insurance will pay for a 30-day treatment. If you have anybody that needs like a longer type of treatment, it's usually going to be an out-of-pocket expense. So, and we just have to look at what the person needs. If they're in their own home and they are using the tools that are limited that they don't really have, then what is that going to look like as far as their stabilization? How are they going to be able to manage the daily activities of their lives? And if they don't, with the structure that they have for treatment, if that's not enough, then we have to look at um, kind of going up a step. It's like almost I need to flip this graphic. Well, this is what you have right now. I'm constantly modifying my presentations, I swear. So switching over to just more of a DSM focus and and we'll talk more about this for sure, about cultural assessment implications. There's the case study in chapter 2 that I'm going to refer back to when we meet next week. But it's so important for us to just take into consideration the biases that we have with our worldviews, with, what goes on behind the scenes of our belief system in order for us to be able to understand, are we aligning correctly with the client's worldviews, with their background? Are we calling the same things abnormal? What the DSM, some of the biggest criticisms of the DSM is that this is really written for a white, I'm just going to say this, like a white demographic, a white Anglo-European demographic that has a particular way of talking about problems, that has a particular way of seeking treatment, that has a particular way of describing behavior. And it doesn't really fit with the general, like it doesn't completely translate into every single culture and population. And so it's important for us to think about, how do our assumptions of the world and our assumptions in relationships, our assumptions that we make with regard to what we deem as problematic behavior, do those fit with regard to, I'm going to get this out of the way, do those fit with regard to somebody else's worldview of what we say is problematic versus what they say? I'll tell you as an example. So I work at Sharp Chula Vista. This is my full-time job. And in addition to me being an adjunct professor and getting to work in my private practice, and I came from Sharp Mesa Vista, as I've indicated, and at Sharp Mesa Vista, there are a lot of white people, a lot of white people. And what I took for granted so much was the ability to just talk about my problems, like with my friends, not with my patients, but with my friends that also work there. And so, I was pretty mentally healthy in a lot of ways because I had such a strong network of support. And I would say that this is true for so many clinicians that work at Sharp Mesa Vista. It's like it's a great thing to work around a lot of people that are also therapists, because the way that they ask you questions, the general level of openness, of vulnerability, like if anything stressful ever happened, like I would come to work and I'd have a network of people that'd be able to support me no matter what. And so that's something that I took for granted a lot. The other thing that I took for granted was just the general level of openness to talk about problems. And so when I came to Sharp Chula Vista, I came to Sharp Chula Vista to essentially launch a program to support frontline staff with their stress wellness. And at the time, it was trauma from COVID. But a lot of the nurses that I support are Filipino, they're Latinx, like they come from backgrounds where their assumptions about what behavior is abnormal is so different, i.e., there is definitely a much more closed background of how they talk about mental health issues. And what I learned, unfortunately, pretty quickly was, especially like Filipino family systems, is they don't really like to talk about problems addressing mental health issues. There is a lot of stigma about people being crazy, and essentially that it impairs your level of functioning if you have depression or anxiety or something worse, goodness. And so the thing that would be tough is like, me coming in with my cultural beliefs as a therapist and as just a person in the world and trying to get people that I could see without even having met them before were very distressed to talk about their distress. That's what my job is to provide this as needed support. And so people didn't want to talk to me. Like they didn't want to come into my office. I'd round on the units. I'd be like, hey, I'm here to be able to help you. And they'd be like, I'm fine. I'm like, well, no, you are not. I can see that you're fine, that you're not fine. And so it took a while, but I remember I had a nurse came into my office and I do like 20-minute sessions because I'm not out. This is another conversation for another time in terms of the specifics of what I do, but I'm not here to do therapy with people. I'm here to connect people to resources. Often that goes that, they need to tell me what's going on first. But so usually it's like a 20-minute check-in, and then I'll make a plan with them. Like we do quick treatment plans, and then I send them on their way. Well, this nurse didn't want to talk to me. Like they didn't open it for like 20 minutes. Like they couldn't say anything, but then they didn't want to leave either. And I was like, what is going on? And so what they had shared was like, I've been doing this for 6 years. At this point, it was like mid 2022 said that I've seen all of this crap with COVID. I've been really traumatized. I've been struggling with my mental health, and I cannot talk up to my family about this. I can't talk to them at all because they'll just tell me to be able to go to work, be brave, you know, just deal with it. And everything will be fine, and it's not fine. And so, what they were really grappling with was like, how do I make sense of something that I think is problematic when my family is telling me that it's not a problem? To me, this was profound because they were really in between two worlds of like, I'm supposed to act, think, and feel this way about my problem, i.e., I'm not supposed to call it a problem. It's just part of the job. And the nurse's background was that all of her family members were nurses. And this is like a really significant, I mean, it's just a very culturally connected profession. There are a lot of Filipino nurses or Filipina nurses. And so she had grown up in an environment where you do hard work and it affects you, but it's not really something that you come home and talk a lot about. It's just something that's like generally accepted. And there's something essentially kind of inherently wrong with you if you are negatively affected by the job. This is hard work, what these nurses do, what all nurses do. I just am amazed every day when I see them do this work. But to what I would say was like they're ignoring their problems. But I had to be so cognizant of there is a very significant framework that I can't touch. But I have to help a person recognize when something is problematic for them and give them support based on what they can really connect to. So for this person, we had to work together for a couple of sessions to try to figure out how they could actually receive treatment, what was okay to tell their family system, how to be able to, I mean, for a while they were kind of like sneaking around going to therapy and getting mental health treatment and figuring out a way to gradually expose their family to this idea that what was happening at work was generally challenging for them and that there wasn't anything wrong with receiving support. But a lot of people wouldn't say that their trauma was actually abnormal. It was like, this is what we do, this is hard work, even though it was during COVID. Regardless, it was still a really big struggle. And so it just puts things into perspective about what we take for granted with regard to how we assess and determine that things are problematic or not. And so, I'll say in this slide that it's tough because we have to walk a fine line of not overly diagnosing people, not overly mischaracterizing something that is culturally related or cultural or understood through a cultural lens as a problem, as pathology, because the reality of different populations in minority populations, especially over time, is that their behavior has been mischaracterized, misdiagnosed, marginalized through what other white clinicians, I'll say it, have diagnosed and conceptualized, and just things that they have essentially misattributed as far as behaviors within those particular groups. And they call it pathology. And so we have to figure out how to be able to identify, hey, how do we not speak about somebody through a pejorative lens? Like how, if we think that somebody meets criteria for a DSM diagnosis, are we zooming out? Are we making sure that this isn't actually a reaction to a systemic issue? Is this a reaction to poverty? Is this a response to a bigger issue in their environment, not a matter just of their genetics and what their environment has essentially, ooh, I have to insert a slide for next time. I just reminded myself. Um, Ask me about the diathesis stress model if I don't already put it in the slides, but I will. But there's something I'll talk to you about next week. But we have to, or there's a difference between, hey, am I set up genetically for this predisposition, and because I'm going through particular stressors, that brings this pathology out, versus like, if I wasn't in this particular environment, if I wasn't going through this particular stressor or trauma with my family, with my friend, with my community, then would this actually be something that I would have as a diagnosis? And that's really subjective. That can be the chicken or the egg, but we have to look at and make sure that we are being sensitive, that we are being as objective as possible when we are using diagnostic labels, when we're using diagnostic words, when we're focusing on something that we deem as a problem. We have to make sure that this is individualized and that we take all of the contextual components of what a person is suffering with into account. It is easy for us to be like, oh, it's this diagnosis, it's this diagnosis. And a lot of times that really makes sense in terms of what a person is experiencing. But that's where I'm going to loop back this model. So I'm going to just leave this here, and we'll talk more about this in our next didactic about whether something is actually problematic or not, whether that's a diagnosis or not. Okay, so another way just to view client outcomes is what treatment options and available resources do they have? What are the contextual factors that actually make sense of in terms of identifying that something is problematic or not? And then how do we use the DSM and essentially a medical treatment model to be able to support them and give them the necessary tools for their recoveries? Um, and so this is where I get into this idea. So this isn't in the textbook. So these slides that I'm going to talk about aren't in the textbook, but this is information that you need to know because we'll be talking about this in the course. But we have different opportunities to either conceptualize something through the lens of a diagnosis or actually formalize a diagnosis. Depending on where you work in your practicum, depending on where you work after that, you will either be in control of identifying a diagnosis in the person's chart or you won't. You'll see that there's somebody that's responsible for that, whether it's a licensed professional or licensed clinician, um, or it's on you. It just depends. And then I support some of my practicum students that aren't even in practicum anymore that are associates. There's one in particular that I support that we've had a really great working relationship, and he'll call me up because he works at a site, he works in a private practice group, and his supervisor really doesn't operate through the lens of a diagnosis, but he's working with a person that at least has a delusional disorder. We'll talk about that in week 6. but at least has a delusional disorder. And if we didn't address that and we didn't give that attribution to helping to conceptualize what their client is going through, then my not my associate, but the associate would be really lost in treatment. And so that's where he'll call me from time to time to essentially collaborate on the conceptual lens and focus of treatment because of the fact that that's absent at his site. Different clinicians do things differently. I just think that it's really helpful to identify what kind of diagnostic framework we're working for and then figure out how to use that information to guide us in treatment. So the principal diagnosis, this is really like the overall set in stone diagnosis, regardless of what level of authority you have. But these are just different words or different types of, I'm trying to think of what the way to say this is. These are different processes or evolutions of how we start to think about somebody's contextual problems through the lens of a diagnosis. So the principal diagnosis, this is like the overarching notion of like, this is their primary issue, okay? So this is the primary, secondary, or tertiary disorder that's driving what their problems are. So what this means is that people can have more than one diagnosis. They can have major depressive disorder, with substance use disorder and an adjustment disorder, or and a problem that's essentially been managed. So they might have, um, I don't know, anxiety disorder by history or something like this. So we can cite, hey, the primary principal diagnosis is this, the secondary is this, and then the tertiary is this, if they have all three. Differential diagnosis, that's how we rule out alternative diagnoses. Again, or in another way to say this is that's how we say, hey, this person has these symptoms. We're going to practice this a lot. This person has these symptoms. I'm not quite sure exactly what the diagnosis is. So I'm going to throw out a couple different options and then I'm going to rule them out by going through more of a precise, systematized method of figuring out what the diagnosis is. And so that's what we are going to focus on during our class. So ruling out means I'm going to essentially factor them out after having reviewed them against one another. The provisional diagnosis is this is something that's like, I've met with this person a few times. It seems like it could be it, but I don't have enough certainty that it absolutely is. So that's what we could identify as like a provisional diagnosis. This is something that's like, I think it is, but I need to really continue to do more assessment. I need to really review my DSM, consult with somebody about this, and then I'll have a working understanding of their diagnosis. And that's what we call working diagnosis. So it's like after having made sure that we've demonstrated due diligence, then this is the clinician would confirm the diagnosis. Now, a working diagnosis and a principal diagnosis essentially are interchangeable. The working diagnosis is just a different type of a semantic. And it just depends on like, so you just might hear principal diagnosis or you might hear working diagnosis. But what this means is that the clinician has confirmed that, hey, this is what it is. This is what it really seems to be given all of the information that I've obtained and that I've witnessed directly and indirectly. Comorbidities, this is where we can have more than one diagnosis. So that would be that different diagnoses can coexist within the same individual. And it's really a matter of what are they coming in with that is the primary level of focus. So if a person if they're drinking and they're very depressed and they are not coming in to manage their drinking, spoiler alert, we really want to give them support around their drinking because their drinking is at least really perpetuating the depression, or the depression is actually secondary to the alcohol use, depending on which came first. But these can be happening together. It's just a matter of how we are determining where we're starting and like what's the biggest focus that we're going to work on in treatment first. And so that's where major depressive disorder might be primary or it might be secondary, depending on how we're going to start in treatment. And again, we just have to consider who has the ability to actually determine the diagnosis. But I always want you to be thinking, at least in your notes, in your minds, of like, hey, what are the different diagnoses that this person could be experiencing, and how do I know, and how can I confirm that? And I'll just share one more thing with you about this is that, I've had licensed clinicians that are really good clinicians that have been my direct reports when I was at Sharp Mesa Vista. And I remember one time one of my therapists just was a fantastic, is a fantastic therapist, came into treatment team and he said, "Hey, I'm really stuck with this person in group, and they have this behavior, they're really reactive, and they also say that they're really depressed and that they're anxious, and I just can't figure out what's going on and how to treat them. And I've tried this and it doesn't really work, and I've tried this and it doesn't really work, and they keep saying that, oh, well, that's making my anxiety worse, or I can't do this because, this relationship is really affecting me and now my depression's worse." And so they just felt like it was a game of whack-a-mole. And so what I was like, well, did you formalize what the diagnosis is? Like I understand because at Sharp, our psychiatrists will create the diagnoses. They might be correct. And just given the difference in terms of how much time um, psychiatrists spend with their patients versus how much time somebody that's running the groups spends with their patients, they may align and sometimes they don't. And this is where we have to demonstrate due diligence to connect that psychiatrist to the clinical conceptualization. But anyway, so my therapist hadn't really taken time to be able to figure that out. And so I was like, hey, let's do this now. And we figured out that it probably was a personality disorder presentation that we were looking at to make sense of a person's depression, make sense of a person's anxiety, reactivity, that was the best fit instead of these diagnoses that could be comorbid, but really actually made sense from a broader clinical picture. And so this is why I think it's so important is it helps give, and then once that clicked, it was like, oh, well, I haven't been giving them the type of treatment that they really need. And we had a completely different treatment plan for that person once we took the time to be able to evaluate what the correct diagnosis probably was. And it was a personality disorder. And so that made all the difference. And so there's something to be said about we don't want you to be wandering around aimlessly just treating symptoms instead of being like, hey, what diagnosis does this have I looked at all of the contextual considerations and like, does this actually seem like this would be appropriate of a diagnosis? And what's the best diagnosis for this? So that's one of the other reasons why it's so important to do this. So the catch-22 of the diagnosis, like it's not necessarily a magic bullet. It doesn't fix everything. On one hand, as far as what the text talks about, we might need a diagnosis, or in a lot of ways for managed care, we do need a diagnosis because this demonstrates that a person's functioning under the DSM is severe enough to warrant that they need the particular level of treatment that they're in. That if they don't have that level of treatment because there is the presence of this diagnosis, that they will continue to suffer and struggle, and that could be very risky for them, for example. So we have to formulate something to demonstrate like, hey, this person really has evidence of why they need treatment, and we've been able to demonstrate that. Then just like what I talked about with my therapist, Ryan, he's so great. And I'm saying this because some of you, if you are ever in the dual program, you might get to work with him. But then it's like this helps us inform, this gives us a framework to inform why the symptoms are the way that they are, what we can expect in terms of the course of those symptoms if they're untreated versus treated, what the implications are for the challenges that might come up with this set of information or these set of behaviors, these set of problems, and what a prognosis is. Like, do they have a favorable diagnosis, or pardon me, do they have a favorable prognosis if they get to have these types of treatment skills and tools? Um, and there's depending on what the person has as far as a diagnosis, there are a bunch of different outcomes that they could have if they do the evidence-based work. So furthermore, having a diagnosis helps us collaborate with our clients or our patients in terms of what they're struggling with, what's wrong with the things that they've been experiencing. Like it puts their experience into context. And this is where we usually see two different types of reactions. Can anybody just, as you're listening to this or watching this, it's like think about there's two primary types of reactions when a person learns that they have a DSM diagnosis. However they learn about it, and hopefully it's in a safe, supportive way. But there's two different reactions. On one hand, we have people that are like, oh my gosh, this makes so much sense. Now I really get what's wrong with me. I get why I've been struggling in this way without relief. I get why this has like been so hard for me in these particular phases of my life. This all makes sense. And I have a framework to really normalize and validate my experience. On the other hand, we have understandably a group of people that are like, oh my gosh, are you kidding me? This is what's wrong with me. Oh, I'm doomed. My life is going to be so negatively affected. People are going to look at me as a label. I'm going to be stigmatized throughout my life. Those are understandable reactions to have. And so it's our job to be able to support a person in terms of their knowledge and their learning when we deem that it is appropriate to share our working understanding of a diagnosis with a client or a patient. But there are limitations to that. We don't always share that information with people. Ethically, if we know that it's going to be helpful for them, that's where, and we have the backing to do this if we're not licensed, and we have the competence of having made that decision through observation, through supervision, through collaboration, through consultation. That's the word I was looking for. That's where, and we know that the person can receive this information effectively, then that's where it could be indicated to share that information. But if it's something that we think is going to be problematic for the person, pardon me, in the sense that they're like, oh my gosh, I'm doomed. The world is over. This is what's going to be wrong with me for the rest of my life. Maybe I'm exaggerating for effect, but people have that type of reaction. Then we want to be really strategic with if we ever share that information because we don't want it to be something that interferes with treatment. We want it to be something that is really a useful tool and a useful format to guide the treatment, to be able to support the treatment without it being something that is concretely always indicated or concretely something that we can't share because the person is going to have a meltdown. So that's where I'm speaking to the other side of this retro rainbow of is it going to be from hindering the client psychologically in any way? The other, other components of how this might be challenging is, um, and the textbook talks a lot about this. I always never really thought that it was a big enough problem. But I always thought that it wasn't a big big enough problem until I had a client in my private practice who once received a diagnosis for schizophrenia. He has never had schizophrenia before, but he has had a significant history of substance use. And I'm sure that there have been times where he's been in a higher level of care, i.e., a hospital, and he was having some sort of hallucination, some sort of delusion, some sort of paranoia. For whatever reason, he was given that diagnosis of schizophrenia like years ago. And then just last year, he was hospitalized and I don't know, that diagnosis made its way through the healthcare record, and somebody from the emergency room said, "Oh, you've been given this diagnosis of schizophrenia." And my client like could not handle it, was so upset about it, had been perseverating on it. It was like, this is all people see me as somebody with schizophrenia. That's not even accurate. I had no idea that that was even going to come out in that way and that it was furthermore going to affect my client the way that it did. And so that's really, something that's the downside of this is that all of the, if you're doing something electronically, more or less, it's going to have a track record. It's going to have an evolving life. And so we have to figure out how to give the correct diagnosis and how to be good stewards of our ability to make a diagnosis, but also recognizing that that's not perhaps always going to fit. That may not, I mean, that genuinely was not the right diagnosis for him. I don't think that that was really good practice, but I have no idea the circumstances of how that came to be. But, it's like it's kind of a moving target. And so we have to make our clients aware of the fact that just with everything being electronic, that it follow them
and could change the way that they could receive treatment. And so it's a lot to swallow in that regard. But just to know that this is something that's like can happen in this particular way and can affect a person pretty either in a way that opens doors, or the fear is that it closes doors. And so we just have to recognize that like this is something that could come up in the process. And then also what the text talks about is just that sometimes, we have to like either really ramp up a diagnostic label or a diagnosis in order to make sure that somebody has the tools and resources needed. And sometimes we have to minimize it because we don't want to have this negatively affect them. I will talk about this when we get into schizophrenia spectrum and psychotic disorders as it relates to schizophrenia and as it relates to schizoaffective disorder, because this is where it can become political of like schizophrenia is a big diagnosis, just as I said, and it can have a lot of implications, and we want to make sure that we are being cautious in terms of how and when we arrive there. Okay, so just with so what this actually translates to is that what the text talks about, I'm kind of really summarizing this. The text talks about like, hey, if we are going to be meeting with people and we have the opportunity to incorporate our diagnostic conceptualization into the work, then we need to bring this up in informed consent of like, hey, if we determine that a diagnosis is a helpful tool to use in terms of your treatment, then here's where that information is going to live. Here's where it's going to live in your chart. Here's where it might go after we terminate treatment. These are the implications of that. The problem is that if you're working in managed care, you don't have that choice to include it or not. You have to include it. So it's helpful to really help your patients or clients that are going into treatment using their private insurance to recognize that like that's something that we have to do for to justify treatment, and that these are the ways that it could impact their lives. This is not necessarily on you to do this as practicum students, but just to know that when you are associates, when you have the ability to work more directly with your patients or clients, what that might actually look like, to give them a clearer sense of what happens behind the scenes. Otherwise, we have to be able to use our clinical judgment when our clients ask to know their diagnosis. So some people will come in and they're like, hey, what's my diagnosis? And you might actually have that working perception in your mind, but that's where we go back to this, like, how is it going to be helpful and how is it going to be hindering? And is it something that we need to accommodate that request? Sometimes we get pressure from parents, sometimes we get pressure from schools, from the courts to determine a diagnosis. This is where I always want to include a licensed clinician that has a higher degree than me to do that, like a physician, because just often they have bigger liability. And I just don't always know what's going to be used when a third party is asking, that's not paying for treatment, but when a third party, i.e. school, the courts, etc., is asking for a diagnosis. That's where I kind of push back because, or I get reticent, because people don't always have the competency and focus on labels that can either, again, be helpful or detrimental for a person. So if we're talking to our clients about the benefits and risks of having a diagnosis, going back to what I said, how is this something that could be helpful for them? How is it something that we need to be aware of so we can help manage a negative reaction that they have to this potentially just, having a negative effect in terms of their prognosis? And then what the text reminds us of is that they have options. The client has option, the patient has option not to actually submit a diagnosis to submit as a third-party reimbursement. But what that means is that they may not actually receive authorization from insurance to use their treatment, or authorization from insurance to be in treatment, which would come out of their pocket. And so it's like, I don't want any psychiatric records to follow me. I don't want insurance to know. And there's different degrees of whether this is something that actually is going to be used against them or not, or how it's going to be shared. But the downside is that, okay, if you don't have a paper trail, then that's great because nobody has access to this information that could potentially be used against you. But the downside is that nobody's going to authorize treatment because they don't know what is actually
a framework for understanding your problems. And so you're just a worried, well person, and they're not going to authorize any treatment for that, as what they could argue. So they're just risks and benefits that can go to either one, and this is where it's up to the person to make that decision if they're really struggling with the idea of having this paper trail of their diagnosis. Um, and so we just have to, we'll talk more about diagnostic considerations, but like we really will shift next week to talk about the overall context of what goes into a person's life that can um, exacerbate their symptomatology, that can assess with help with their resources, etc. I'm going to leave that for next time. The one thing that I really wanted to say in terms of the last chapter is a lot of the stuff is pretty straightforward, and some of the things I think you'll continue to have more education, and you have just different classes that will go into this. But these slides, I don't think you actually have any sort of formalized education about this in our program. And so I wanted to demonstrate due diligence and make sure, because these are the things that like I hear so commonly, and I saw this in the textbook in chapter 3, where I think it was Tony's mom died by suicide, but the vignette said she completed suicide. And I was like, oh, that is not correct terminology. And then the text said that that was incorrect terminology. So the right hand was not talking to the left on the editing end or the publishing end. But so this is what I want you to be aware of. And this, I promise, is going to be very helpful information for you. This is so ubiquitous in terms of us and entering into the clinical world. And so this is where it's so important to make sure that you are aware of what is acceptable versus unacceptable. The only acceptable terms that we have um, are attempted suicide and die by suicide. All of these terms, completed suicide, failed attempt, successful suicide, commit suicide, parasuicide, non-fatal suicide, suicide gesture, manipulative act, suicide threat, all of these are deemed inappropriate, unacceptable by the American Society of Suicide. Oh, I think no, it's not that acronym. It's something else. It's essentially the national board that makes these decisions about suicide risk and awareness. Um, but all of these terms are outdated because what they essentially, the subtext to them is that suicide is either an accomplishment or not dying by suicide, trying to attempt suicide and not being successful is a failure. And so we don't want to ascribe success or completion to this because this is so much deeper than just a behavior and whether somebody passed or failed. It can be pejorative, it can be stigmatizing, it can really reduce the experience that the person is having. And so that's where it's like the parasite, the non-fatal suicide, a suicide gesture, all of that stuff really becomes stigmatizing when you think about it this way versus like this person attempted to kill themselves or they actually died by suicide. I love how it's very black and white in that regard. So just please be aware of what you hear and what you say, and just focus on these bottom components of this, okay? Um, so just some common misconceptions about people that are suicidal as the such an overall common misconception about this is that asking about suicide is actually going to make it worse. And I remember taking my psychodiagnostics class in um, in graduate school, and I was terrified just even at the thought of asking somebody if they wanted to kill themselves, if they were thinking about suicide, because I was just so terrified that they're in this fragile state, and if I ask about it, then they're all of a sudden be like, you know what? Yeah, because you asked me about it. Yeah, I'm gonna do that now. It's not how it works. The conceptualization of this is that when people want to die by suicide, they are feeling disconnected from others. They are feeling like others would be so much better off without them. They feel alone. They feel isolated. They feel overwhelmed. They feel, in short, incapable of being able to deal with the stressors of their life. And they believe that suicide truly is the only solution. The problem is that when we don't ask about it, we don't give them an opportunity to be seen in that pain and suffering. And so when we ask, hey, are you thinking about suicide? Are you thinking about killing yourself? I found that the most direct way is the best way because it speaks to the heart of what the person is experiencing. We're demonstrating that we are taking it seriously by not tiptoeing around the way that we ask the question. We're demonstrating that we're not afraid of what this person is experiencing, and it is something that we can handle and it's something that we can support them on. We are showing that we're not like we don't fall into that trap of it being stigmatizing. There's so many things that just being direct about this actually does as far as treatment is concerned. And so that's where it's very important to make sure that, and this is, what the textbook talks about with regard to homicidal patients, talking to people that are experiencing intimate partner violence is like the more direct we are about this, obviously there's different limitations for our safety with those other two examples that we have to make sure that if we're asking questions about people that we think are potentially dangerous to others, and it changes the way that we approach things. But there's something to be said about somebody that is suffering in silence and for us to be like, I see you. And I'm also aware of the fact that like your life could be at risk because of how much you're suffering. I tell you, it makes a huge difference. And so it will not make it worse. If anything, it will actually make it better because feel seen and validated in what they're experiencing. Another myth of clients or patients that engage in cutting are suicidal. This is typically not the case at all. And I think sometimes people just react to cutting of like, oh my gosh, this person is doing this. They could cut into a vein. I've seen deep cuts, and it doesn't mean that we don't take that seriously. But often when people are engaging in cutting, which we call non-suicidal self-injurious behaviors, it's because they're not actually trying to die by suicide. They are really trying to use this as a coping mechanism to take control of their pain or to redirect their pain. Most people are not doing it to kill. I just want you to think about this. They're not doing it to kill, but to cope. Okay. They just don't have the tools and the skills to be able to deal with, at times, such deep-rooted systemic historical, you know, uh, pain that feels like the only way that I could divert this pain or redirect this pain is to take it out in a different part of my body. So, like I said, doesn't mean that we don't take it seriously, but we shouldn't use them interchangeably with one another. We still have to demonstrate due diligence to do suicide risk assessment. But if somebody's cutting, then a lot of times they're coping. They're just not coping effectively, and we have to teach them other tools for that type of distress tolerance. Another myth, and I totally get that when people die by when people unfortunately die by suicide, it creates the process of grief, obviously for those that survive them. A lot of times out of anger, people will say, "Oh, this is selfish. This person killed themselves, and that was such a selfish way out." And I genuinely think that the opposite is true in terms of the mind of somebody that is contemplating suicide. Often what they're thinking is, others would be better off without me because I am such a burden on them. I'm such a burden to deal with and to take care of that it would be easier for me to just, fall asleep and not wake up and to be alleviated from the pain and the suffering that I'm experiencing. But then my loved ones don't have to pay for me in treatment anymore. They don't have to worry about me. They don't have to have to come to treatment with me or deal with all my doctors, or they don't have to do all that stuff. I'm just taking that away. And that focus is so myopic. Like they are just so internally focused on their pain, and they believe that that is the best option for them and for everybody else. And it's tough to have to explain this to people that it's like, no, I will always be upset. That client that I talked about that was misdiagnosed with schizophrenia had a suicide attempt. And long story short, I had been telling them for a while about how this would not be something that everybody would feel good about. And they had a suicide attempt about like 9 months into our treatment. And I just remember telling them, like, I would never get over this. I would always, always miss you. I'd always be sad. I've worked with this person for years and years, and we've gone on and off with our treatment. But it was like, I'm not ever going to feel good about the fact that you died. But for somebody that is so connected to their pain, what is a struggle is for them to see a perspective like that because they just see that the pain is so clouding of their decision and their rational processes. But so this is where I'm going to give this to you. I promise you that this will be so helpful. Come back to this model for your suicide risk conceptualization. But there's a lot of things that put people at risk for attempting suicide. There's a lot of things that put people at risk for wanting to kill themselves or to consider suicide. This is the easiest, most straightforward way to be able to assess a person in terms of their level of risk. And what Thomas Joyner is somebody whose son died by suicide. And so he created, unfortunately, through that experience, was so led to better understand um, why people actually die by suicide. And so he did a bunch of research. And what he found is that there are three prominent factors that occur in anybody who's considering suicide. There is perceived burdensomeness, thwarted belongingness, and acquired capability. And what perceived burdensomeness is what I was saying in the last slide, is I believe that I'm a burden and that people will be better off without me because I'm so much to take care of that people do not have the capacity, and me being such a burden to them, alleviating that from them is going to really just make their lives better. And then I don't have to be around to deal with that and to cause them that type of pain and suffering. And then there's thwarted belongingness of like, I don't fit in, I don't belong, nobody understands me, people don't like me, they don't accept me. A lot of this can be a cognitive distortion. A lot of this can be the byproduct of how we feel when we're depressed, right? We isolate, we think negative thoughts about ourselves, like we think the worst, right? So what this theory says is that cover up acquired capability, but if we're just looking at these two components, if a person really has perceived burdensomeness and thwarted belongingness, then what that means is that they are at a heightened risk for a desire to die. Okay. Like these are the people that are going to say, I just want to fall asleep and not wake up. Like if this opportunity was just given to me and I didn't have to do anything to hurt myself, that would be really great because that would just take away all my problems. We have to demonstrate due diligence to tell them that it's much more complicated than that, but this is the gist of it, okay? Now, they could have these two things, but not have what we call acquired capability, which means the ability to die or not being afraid of death, okay? So people can feel like they're a burden to others, feel like they don't fit in. But when you ask them, and I would always encourage people to do this because our clients and our patients react so favorably to this. But when I say, do you fear death? To me, this always gives me an understanding of if somebody's actually at risk or not. A lot of people will say, yeah, I mean, like, I want to die, but like, I actually don't like pain. I don't want to hurt myself. Like, the idea of me actually doing something to throw myself off of a bridge or to swallow a bunch of pills or to like stab myself, all that stuff, I could not do that to myself. And to me, it's like, oh, okay, that helps me categorize or really better understand that this person is walking around with a cloud over them that all they want to do is to have that pain alleviated. But when it comes down to imminent risk, that's not there. Until somebody starts to actually disconnect from the potential pain that a suicide risk attempt would cause, I'm not worried about them going out and leaving the session or discharging from the hospital and attempting suicide. Now, if a person has acquired capability, that means that they do not have that innate fear that we all are equipped with as humans. They don't have that fear of death. Now, where that comes from is an exposure to trauma, exposure to death, whether that's they've seen death through war, through like generational trauma. They've been exposed to this in their communities that it's normalized. There's a desensitization to death. That's the better way to say that. There's a desensitization to death. And if people have had multiple suicide attempts and they're pretty significant, then they have acquired capability. So a person can have acquired capability through the desensitization of death. And if it's not through their own suicide attempts, but more so like trauma, again, war, other sort of community violence exposure, they have that desensitization, but they may not actually at the time have perceived burdensomeness or thwarted belongingness. However, when we see all three, that a person is like, and that was my client that I was talking about that had the suicide attempt. They've had so many near fatal suicide attempts before. And so, like, the risk for them to die by suicide was always, unfortunately, really high. And they're in long term treatment, fortunately, now out of state. And I'm so happy that they're in a safe, secure place. But like when they're using, they're not doing well at all. And it makes a really big difference in terms of just, you know, what risk that I determine them to be at. But when they have all three of these factors of perceived burdensomeness, thwarted belongingness, and the fact that my client does not fear death, that's when I know that I really need to keep an eye on them and that they need more support. So please come back to this. Please use this. If you have any questions about this, let me know. But I promise you, this is going to be worth its weight in gold as far as your overall. Take this with you through the course of your clinical lives and ask these questions. And I promise you, it makes such a big difference in terms of your ability to quickly determine somebody's risk for suicide. It will make all the difference in the world. And I can't wait to hear about your experience with that, hopefully positive experience, not speaking to obviously the nature of what patients are going through. So I wanted to give you that. Okay. And then this is lastly, this is we used to do no suicide contracts. Like way back in the day, we would essentially make people promise that they wouldn't kill themselves. It was terrible. It was crappy. It was awful. This is a patient safety plan template. And all I want to say about this, so you'll see this, like all this is common practice now, but these are fantastic tools to use for your treatment. What happens is that people complete this at the beginning of treatment. It's a strength-based approach. What this does is it gives the person the ability to identify, hey, what are warning signs that I know that a crisis could happen? What are the warning signs in terms of my thoughts, my feelings, how I isolate? What are the more, if I think about the last couple times that I've really been struggling, where's the starting point for that? And knowing this is so helpful. That's not information that everybody always has about themselves. But then what we can do is insert coping mechanisms. Hey, as soon as you start to feel like nobody cares about you, what can we do to manage that? So it doesn't continue to escalate to the point where you are really giving away all your stuff because you are convinced that nobody cares about you and that people are going to be better off without you. And so what we try to do is to then have like, what are coping skills that you can use as soon as you're recognizing that these warning signs are there? How can you take your mind off of things through distraction? How can you relax? How can you engage in physical activity? What are other evidence-based coping skills if you know this that we could use? If that doesn't work, then it's like, who can you call and connect with that can be helpful for you? How can you get out of the house? Where can you go that can shift your mood, that can give you a difference of perspective? If that still doesn't help, then who do you know in your life, friends, family, significant other that you can talk to be like, hey, I'm really struggling. I've got these thoughts that nobody cares about me. The last time this happened, I got really in on myself and I just didn't find any way out. And then this is what happened as a result. And I don't want to get there. Please, please help me. Please support me. A lot of times that works. That's helpful. If it still doesn't, if you call the people and you're like, hey, I'm really struggling with this, please let's figure out a way that I could not be struggling with this. If that still doesn't help, then that's where we would direct somebody, okay, call your therapist, call your psychiatrist. If it's severe, call an emergency service, call 911, and ask for PERT, go to Sharp Mesa Vista, whatever it is. This is such an underutilized treatment plan that is like you could take this from your client or your patient's chart and just plug it in to their treatment. They've already approved of this because this is coming from their mouths and that these are things that can really be helpful. But I see it so often where people don't use it. And it's like, this is gold. Why are we not actually incorporating this into their treatment in a skills-based way? So I just wanted to give you this heads up before you go into your practicums that you're going to see this. And if you can use this, the best thing is when when patients actually write this out, we're supposed to give them a copy at Sharp. They write it out and it's like, put this somewhere. There's even an app, it's called Safety Plan, that they can use to go back to, like, oh yeah, I have to do this. I have to call this person. I have to go to this place. I like when my patients have used this in the past, oh my gosh, it is so helpful in reducing the intensity of their emotional state. It is so helpful in allowing their strengths to kick in and to actually receive that support. And so I wanted to just to bring that to your awareness. And then the last component, step six, is making the environment safe, is means restriction. If you are vulnerable, if you're not in a good place, if these warning signs are starting to take over, then what do we need to do to remove any potential like access to fatal means, so guns, pills, a car, whatever it is, cleaning products, I don't know whatever the person's method of choice is, how do we take that out now where you're clear-headed so that if it gets to this point in your life where you are not doing well and you are really convinced that suicide is the only way out of this, that you can be without your method. And there's a lot of research that shows that people are actually most at risk for suicide and for attempting suicide when they have access to their one particular method. When they don't have access to that method, they are not going to attempt suicide. That to me is super fascinating. So that's where we want to make sure that we're going to demonstrate due diligence and assess for what access to lethal means does a person have if they have any potential risk for attempting suicide. Okay. So that's all the stuff that I wanted to make sure I'm demonstrating due diligence to give you. I hope it's helpful. It may not be something that you use right now, but please, please come back to this. Email me if you have any questions, if you need anything. Please remember to complete your video introductions on the discussion tab by Sunday at midnight. I can't wait to see you all next week. I will post the mental status exam video for you to watch, and that goes into the module of what your assigned reading is. So that's coming. But thanks so much, everybody. Thanks for sticking around. Take care.